Okay, we're ready to get started. The beauty of being the first presenter is that you're the first presenter. The horror of being the first presenter is all the audio-visual glitches happen to you. So, but they're out now. So all the other presenters will owe me beers for struggling through this. So the good news is the topic is pretty simple, pretty straightforward, and is really easy. So that makes up for the fact that we're starting late. So my name's Dan Rauh. I'm from the University of Cincinnati. I'm a flight nurse practitioner there, and I have you for about the next 45 minutes. I'm going to try to finish up a little early. It's all going to be dependent on your synapses. This is really ideally a class that you do with a smaller group so that we can have more interaction. Lucky for you, this is a bigger group, so there won't have to be any interaction, so nobody will actually have to be picked out except just the people in the front row. So that'll be your reward for sitting in front, right? No, so we'll move through here. The title of this is Kicking the Ass of Metabolic Acidosis, and I truly believe that this is really a very simple concept. The problem is when it was explained to you, whether that was in medical school, nursing school, paramedic school, largely the people that were explaining it to you didn't really understand it, so they just passed the savings along to you, so you never really understood it, and then when you've taught people, unless you really understood it, you pass that savings right along to them. So how many Philadelphia Phillies fans here? How many Philadelphia people here? All right, so we got a few. All right, this is sort of a bipartisan crowd. So for the Philadelphia Phillies fan, I need to know, who is that guy in the top left? I'm ashamed. Anybody? That is the Rudy of Philadelphia. And the guy in the bottom, does anybody know the guy in the bottom? Yes, right on, right on. So the guy on the top left is Vince Papale. He was a walk-on to the Philadelphia Eagles. They were terrible back in the 70s, much like the Bengals always are. And they essentially put out the bat flag, or the bat light, and said, we need some help, and we need to boost ticket sales. So they just had an ordinary guy, he was a bartender, who came out, tried out for the Philadelphia Eagles, and made the team, and he played there for 3 seasons. So there was a movie played by Mark Wahlberg about him. So he's kind of the Rudy of the Philadelphia Eagles football program. My favorite guy is this guy. That's the 1998 Eagles court judge, Seamus McCaffrey. So Eagles fans have a notorious reputation of being, well, mouth breathers. So it got so bad they would have 60 to 70 fights per game, and they finally realized that when somebody brought in a flare gun and shot it from one side of the stadium to the other, that this has gone too far. We got to do something about this. So they started a courtroom in the stadium. So they'd drag all these drunken shorebilly or hillbillies or shorebillies, whatever, down in. They would actually judge, jury, and execution right in the basement of the stadium. So he had his own courtroom set up down there. So you know that your football fans have really gone to the next level when you have a court inside of the stadium, right? So a source of wild entertainment for me. All right, so with respect to this metabolic acidosis thing, what's the plan here? So at the end of the day, or at the end of this 45 minutes to an hour, this is what you're going to be able to do, and I feel that with a high degree of comfort. Number one, you're going to be able to discuss what is an anion gap acidosis, and you'll be able to tell people more about anion gap acidosis than they'll probably ever want to know. I'm going to teach you how to do the Henderson-Hasselbalch equation and the Winner's formula in your head. And I'll show you what those formulas are, and you'll be impressed with yourself at the end of the day. So we're going to learn about how to solve multiple complex equations. So this is going to be high-end, algebraic, in some cases geometric stuff. So this is really high-level thinking, so you got to really be locked in for this. On top of identifying the primary and the secondary disorder, or the second primary disorder, I'm going to teach you how to find a third hidden metabolic disorder. So if you've ever heard of the term triple acid-base disorder, by the time you walk out of here, you're going to be able to identify not only the presence of a triple acid-base disorder, but what it is. No problem. Literally in about 30 seconds, maybe less. And I'm going to generally make you a badass when it comes to stuff that nobody else knows. So that's that one thing, when you have your flight CQI stuff, like yesterday I pulled out of my ass Crutchfield-Jacob disease. We were talking about that, and they're like, that's like my go-to thing. It's like this weird piece of knowledge that I have that nobody else has, and you act like, doesn't everybody know that? You don't know what Crutchfield-Jacob disease is? What's wrong with you, So this will be one of those things when you talk about somebody had a triple acid-base disorder. I will bet you, if your medical director is an ER doc, he won't know how to do that either. So you'll be able to kind of school him a little bit, and most importantly, stump the chump with him and ask him, how do you identify the presence of a triple acid-base disorder? You don't know, do you? So that'll be kind of fun, certainly. So when you think about badasses in EMS, when I was in Italy, my wife and I went to Italy, and you talk about badasses in EMS, these are badasses in EMS. This is the Italian EMS system. So this was in the little town of San Gimignano, which is this really cool hilltop town surrounded by a wall. And this guy sitting out here smoking a cigarette, hanging out with this girl, and they just sit out there and wait for some kind of tragedy in this little town. So those are the badasses of EMS. If you don't have a cool-looking blue Dynamits jacket like that, and you can't smoke a cigarette in the back of your crazy-looking van ambulance, you ain't living, all right? You really should go to Italy, and you could do that. Okay. All right. So we're going to talk about how to do all those objectives through a series of really complex calculations and complicated biochemical concepts. So, if it was easy, everybody do it. This is what's going to separate you from the jackmos that just wear a flight suit and put it on Facebook, right? So this is like what really separates people that just go out. We call them... we have a guy that is in a kind of a local flight service, and nobody here will know him, but he intubates everybody and lets God sort him out, so we call him Paralyzing Craig, because he paralyzes everybody and just intubates them. This is what's going to separate you from those kind of people, and you'll actually understand what it is you're doing, right? So let's talk about the first thing that you got to understand sort of going into this, and I assume that everybody has some baseline level of acid-based knowledge, at least like with respect to blood gases. So first, you have to remember that, and this is something you just have to understand, that if the pH and the PCO2 go in opposite directions, up or down, you have a primary respiratory process, right? So if the pH goes up and the PCO2 goes down, you have a primary respiratory process. Likewise, if the pH and the bicarb go in the same direction, you have a primary metabolic process. So if the pH goes up and the bicarb goes up, then you have a primary metabolic process. You got to know that, all right? So that's sort of concept number one. That's actually concept 0.5, all right? So I got a little chart. So everybody likes graphics, just as a quick reminder. So in respiratory acidosis, pH goes down, PCO2 goes up, and the bicarb, who cares, right? Okay. With respect to the bicarb in the blood gas means not dick. Doesn't mean anything. It's a calculated value, all right? So it's irrelevant. So nobody cares about the bicarb in the blood gas. If you care about the bicarb in the blood gas, the ship's leaving the harbor and you're not in it, all right? So don't even worry about the bicarb in the blood gas. You worry about the bicarb in the BMP. All right. So in metabolic acidosis, the pH goes down, the PCO2, who cares, and the bicarb goes down, right? So that's just the primary process, okay? Respiratory alkalosis, the pH goes up, the PCO2 goes down, and the bicarb, nobody cares. And then finally, metabolic alkalosis, the pH goes up, the bicarb goes, this is a class participation thing, up, right? And the PCO2, nobody cares. So therein is what you need to know about primary disorder, simple blood gas analysis. So I suspect that everybody in this room was probably already here before I got here. I mean, you got this piece, right? This is, sort of elementary. And if you weren't here, you got to get here. So you got to be here, like day one. You got to bring, when you become a new flight nurse or a flight paramedic, there's a lot of stuff that you have to learn. This is probably something you had to bring with you. So you because we can't teach you everything, for God's sake. You know, don't walk into the tail rotor, don't run anywhere, and you got to know about the blood gas thing, right? Okay. So if you've got this, then the rest is a piece of cake. So my goal is to make this as simple and as understandable as possible. All right, and this is kind of what I think about complexity. If you can't explain concepts that are complicated to people and make them simple, then you don't understand that concept well enough, because everything breaks down into a couple simple terms, right? So that's kind of what I think about complexity. So everybody that has been taught blood gases and taught about acid-base balance has seen this stuff, right? Everybody loves, of course, the Winner's formula. I had somebody, who was it, ask about the Winner's formula yesterday in my workshop? Is he in here? Said something about the Winner's formula? Right? All right, yeah, so somebody asked about the Winner's formula. So I promised we'd talk about that today. Below it is the Henderson-Hasselbalch equation. Now, if you're not in a class somewhere where this slide pops up and you immediately think to yourself, I'm out, I got no interest in this, next, then there's something wrong with you. If you like this stuff, you need to go somewhere else, right? So everyone, myself included, when you see formulas like this, you feel like this, right? Because it's terrible. It is absolutely terrible. The good news is you don't need to know that stuff to understand up to triple acid-base disorders, all right? I believe that acid-base balance is probably the most misunderstood concept in modern civilization. Absolutely the most misunderstood concept. Well, maybe the second most misunderstood concept, right? So, right. So, all right. So, everybody likes a good case, right? So let's have a good case, for God's sake. So, your flight crew is called to transport a 24-year-old male from a rural podunk hospital back to a tertiary care center with a diagnosis of DKA. All right? So you're going out to a podunk hospital, bringing him back. So I think it's important, first of all, to understand what exactly is podunk. So the first definition of podunk. So it's an inhabited area near Hartford, Connecticut. I don't know where, I've never been to Hartford, Connecticut, but that's where podunk comes from. Or a swampy place, okay? Merriam-Webster says it's a small, unimportant town, and the Urban Dictionary says, and in case any of you are from small podunk towns, and you think, you know, here's a guy from the big city, not so much. So this is where my farm is. That's in Cedar Grove, Indiana, and that's really the sort of the center of the warehouse, arts, financial district, all right? So that's, and right here, you probably already know this because this is a regional tourist attraction. This right here, this is the damn Cedar Grove Tavern. They make big, fat cat head hamburgers. That's a hamburger as big as a cat's head, right in there. And you can have 2 hamburgers, fries, and a pop, and be out of there, cash only. And there's an ATM machine in there because they don't take credit cards. And 3 bowling lanes behind it inside the same building for about $15. So that's in the Cedar Grove Tavern. Stay the hell out of there. I don't want to be waiting for a table. All right, so, but you know where it is. All right, so, so you're back to this patient, right? So your patient's is a non-compliant type 1 diabetic, hard to imagine. Is there any other kind? It's like a non-compliant dialysis patient. Is there any other kind? Who's been regulating his blood sugar with a new long-acting insulin that's much better than Lantus. It's called methamphetamine. So, and you can't make this up. It's the truth. I mean, this is an actual case, right? So, he is a douche canoe that. The good news is you can't kill him. I'm a firm believer that when you have somebody in the ICU that you think's going to die and that you want to live, the most important thing you can do is put a fistula in them and put them on dialysis. They'll live forever, right? So, all right, so he regulates his blood sugar with methamphetamine. So on his arrival at the outside hospital 30 minutes ago, he was responsive to loud verbal stimulus. Those are his vitals. So 37.1 is his temp, for the people that believe that Fahrenheit wasn't good enough. We really had to go to Celsius. I don't know what was wrong with Fahrenheit in the first place. I still have to get out MedCalc if it's anything other than 37 to figure out what the hell it means. So those are his vital signs. Here's his labs. So if you don't use the Fishbone you got to, it's like using the word cryo instead of cryoprecipitate. It's like using the word rhabdo instead of rhabdomyolysis. You just look cool if you use the Fishbone, right? So these are sodium, potassium, chloride, CO2, BUN, creatinine, and sugar, all right? And then this obviously is the blood gas, right? Okay. So this guy's in a bit of a situation, right? I mean, he's probably maximally compensated on his heart rate. He's pretty acidotic. He's hyperkalemic. And he is sort of the human equivalent of this. So the bear is on his tail. The good news is, of course, that he is, kind of a douchebag, and he has that extra built-in layer of protection. But for the average working person, their life is an immediate peril, right? Okay. So now we get to complex biochemistry concept number 1. So it's important that you know this. This is pretty complex. There will be about 3 of these, all right? So complex biochemistry number 1 is everything starts with the BMP, all right? BMP, basic metabolic panel. Some people call it the Chem 7. There's a bunch of different names for it, but it looks like this. And if you wondered why in the heck are the numbers put in there like they are, this is why. So in the first row, you have the positive ions, called cations, right? In the second row, you have the anions, or the negatively charged ions. Over here, you have the renal function, and the sugar's on the end because we didn't know where to put it, right? Again, there was nothing left. So every time you look at this, just remember positive, negative, kidneys, and sugar, okay? That's why it's like it is. So everything you do with respect to metabolic acidosis starts with the BMP. Second complex concept, sort of complex 1.5, is cations are positive. And if you forget that, next to things like sodium, potassium, you'll see the pluses. Now, I follow the KISS principle, so I only use just sodium. Leave potassium out of there. It just complicates things, and the less numbers you have to add together, the easier it is, right? So the cations that you care about are just sodium. It's the major one. Anions are negative. So they're the other thing besides cations, okay? They're in the second column. Chloride and CO2. So CO2, bicarb, same thing. CO2 is bicarbonate when it's dissolved in plasma. So although it says CO2, when you look at it from this point forward, I want you to think that's bicarb, all right? Makes no sense. I don't know why the hell we couldn't just put bicarb up there. I guess it's much the same reason why you park on a driveway and drive on a parkway. It makes no sense at all. It just is, right? So it just is. So just take that from me, it is. So to address those, you have to remember that your body wants electrical neutrality. And it's going to get it. No matter what. It's going to happen. And if it has to kill you to do it, then that's fine. But it is going to be electrically neutral. All right? So the cations must always equal the anions. And they will. Always, always, always. They will equal out. Not they do sometimes, not they should, they will. And your body will do whatever it takes to make sure that those cations and anions equal out. That's an important concept to remember. And in fact, it will kill you to do that. All right. So with that premise in mind, let's move forward to the next super complex formula. You may need one of those calculators. It's got those abbreviations that nobody really knows what they are, and that is, how do you calculate the anion gap? In some places, the lab calculates the anion gap for you. Even if they do, I still calculate my own because I don't know if they put potassium in there or not. So I always calculate my own anion gap. It's a good habit to get into. And you do that simply by taking the sodium and you subtract the chloride and the CO2. or the bicarb. That's it. That's the anion gap. And immediately, you know if there's a metabolic acidosis. It's that simple. So it's a very complex formula. It's good. The people like it. All right? So always, every patient, calculate the anion gap. And the way that you make sure that you get it right is you always calculate the anion gap. Okay. If the anion gap is less than 15, you're done right there. There is no metabolic acidosis. No anion gap metabolic acidosis. Okay? So all the anion gap really does is just identifies the difference between cations and anions. Now, if you were paying attention, you would have heard me just say that the anion gap identifies the difference between cations and anions. Well, just before I said that the cations and the anions always have to add up, right? So if they always have to add up, why the hell is there an anion gap? Because the gap would imply that they don't add up, that there's some gap between the two, right? So here's sort of a graphical representation. So you have normal sodium's about 140, chloride 105, bicarb 25. So that is 130 minus 140, so the anion gap is 10. That's a normal anion gap. There is no anion gap acidosis. So the question then is, again, back to the original rhetorical question, if the cations and the anions have to add up, what is this gap you speak of? So let's talk about that. The gap is the second complex metabolic or complex biochemical formula that you have to know. So the gap is how, when we first came up with this concept, we accounted for these anions that we couldn't measure. So we knew that they were there, but we couldn't measure them. So we built in this sort of cushion to allow for those anions that we couldn't put a number to and couldn't measure and couldn't put in the BMP, that would then when added to the anions plus the unmeasurable anions would then equal the cations, and everything's equal, and then that's happy and we're good, right? So that's where the anion gap came from. It came from our inability to measure these, what we called previous to now, unmeasurable anions. We can measure them now. So we can actually further delineate what the anion gap really is. So what are those previously unmeasurable anions? They are albumin. Albumin's a weak acid. So if your albumin is markedly off, you have to correct for albumin to identify the anion gap. We're like 3 steps into the nephrology fellowship now, so don't worry too much about that, okay? It's much like if you get a serum calcium level and the albumin is off, you got to get an ionized calcium because calcium is bound to protein, so the serum calcium doesn't mean anything. And along with saying rhabdo and saying cryo, you have to say iCal. Don't say ionized calcium. Saying ionized calcium is equivalent to saying load them up in the chopper. You know, only dorks say that. You don't say that, so it's iCal. All right, so those unmeasurable anions are albumin, lactate, and keto acids. Not ketones, keto acids. You can have ketosis, but not have keto acids. Okay, but keto acids are the third unmeasurable. So when you factor in a normal person without pathology, the normal sodium, the normal chloride and CO2, plus the lactate, the albumin, and the keto acids, the positives and the negatives equal. And there is no gap, and you have electrical neutrality, and everybody's happy, right? All right, so that is what consists of the anion gap: the albumin, the keto acids, and lactate. Okay, so business as usual, normal anion gap, right? So you got a sodium 140, chloride of 25, or chloride of 105, CO2 of 25, the gap's 10. So that's business as usual. So what happens then if now there's a weak acid introduced into the body? You become more acidotic, right? So this weak acid comes in, and it dissociates. That'll be the biggest word I use in here. Don't worry too much about it. It dissociates into hydrogen and an anion. So in that case, what happens is the anion has nowhere to go, so it adds to the anion gap, and the hydrogen goes into the bicarb and is buffered. So when you look at what happens, and it's 1-to-1. That's important to remember. It's 1-to-1. So you have 10 millimoles, for instance, of a weak acid that is introduced into your body. You go into DKA, and you start kicking out keto acids. And 10, for the equivalent of 10 millimoles of keto acids are released into your blood. Your bicarb goes down 10. Your anion gap goes up 10. So now your anion gap's 20. Your bicarb's 15. That's metabolic acidosis, right? Bam. The end. That's it. That's what happens. In a normal patient without pre-existing dysfunctions, this is what happens. If it was 20, this would go down 20, and this would be 5. This would go up 20, and this would be 30. So that's how your body tries to neutralize that acid. And even so what it does is it evens out, not neutralize, it evens out the cations and the anions, and then leaves you with an acidotic state. So here, not acidotic. Here, acidotic. So what I look for when I'm do one of these concepts, so that I know you're following along, if I could just get a guttural sound from someone in the first row, kind of an ugh, or something like, yeah, I get it, no, something, okay? All right. So that is highly complex biochemistry, right? Just remember, 1-to-1. All right. So then, the gap goes up 10, the bicarb drops 10. That's normal compensation in your body. That's what happens. DKA, for instance. Sepsis, for instance. More lactates is produced. So you have more lactate around, the gap goes up, the bicarb goes down. All right. So let's do some complex math. What's the anion gap here? I'm just going to keep 22, right? 122, 144, 22. That is a wide gap. Metabolic acidosis, right. All right. What's the gap? $35. That is wide gap, not just metabolic acidosis, but wide gap. Because that's the gap. The gap's supposed to be less than 15. So that's higher, wide gap, metabolic acidosis. What's the gap? 12. So that is business as usual, right? Normal. Right, good. All right, now we're getting somewhere. So we know there's a wide gap metabolic acidosis. We make that distinction because, of course, there is a narrow gap or non-gap metabolic acidosis. So as soon as you see metabolic acidosis, if you don't already know it, which you did from that calculation, you have to identify, is it a wide gap or a non-gap, or a gap or non-gap? You can call it whatever you want. Wide gap, no gap, whatever you want to call it. It's not narrow gap. It's just wide gap and non-gap, okay? So you've always been taught that the mnemonic for wide gap metabolic acidosis is mud piles. Does anybody remotely remember mud piles? Yes, some? Oh, for God's sake. I work for tips. All right, thank you. Somebody's heard of a wide gap metabolic acidosis, mud piles. Mud piles is what you do. So when you look at and you realize there's a wide gap, then you immediately go to mud piles. What caused that wide gap? Because, it doesn't really do any good to identify something if you don't fix it, right? So you can't fix it until you know what's causing it. So mud piles, methanol, uremia, fancy word for renal failure. DKA. P is peraldehyde. Nobody knows what peraldehyde is, I promise you. It's a drug that we used a long time ago. Nobody cares about it. Doesn't happen, doesn't exist, but it wouldn't be mud piles without it, so we left it in. All right? So it's mud piles. All right, so P for peraldehyde. I for iron or isoionazide or INH. INH is anybody that if you do an internal medicine residency and you take your boards, you do an acute care NP program and you take your boards, INH will be a board question. It's one of the 4 drugs that you give people for TB. Why you need to memorize that, because unless you work in a TB hospital, you're going to look it up every single time. You need to put them on that, but it's just one of those easy questions to ask. So INH is a TB drug. Again, rarely seen. Lactate, often seen, obviously. Ethylene glycol, which is antifreeze, right? And S, salicylates in sepsis. So that's mud piles. So if you have an anion gap acidosis, it will be attributable to one of these causes. So the reality is that mud piles was the old pneumonic. There is a new mnemonic that I'm just going to run through quickly, but as soon as you have a wide gap metabolic acidosis, the next thing you have to identify is there an osmolar gap? And that is an osmolar gap is the difference between the calculated serum osmolality and the measured serum osmolality. That's not something you're going to calculate. You're just going to get it off of the BMP, or I'm sorry, off of the chemistry panel. But serum osmolality essentially is if you take a big beaker of water and you put a drop of blue food coloring in, we'll just assign that a random osmolality value of 10. If you put 3 more drops of water in, we'll assign that a value of 50. The more drops of blue food coloring you put in to put more solute in the solvent, then that is the osmolality goes up. So if you have a lot of sugar, drops of sugar in that fixed beaker, then your osmolality goes up. So there's less water in comparison to the solvent. So in somebody in DKA, they have an osmotic effect, right? So there's more sugar in there compared to the water. Okay, so we don't really have enough time to talk about all the craziness of the osmolar gap, but suffice to say, for acid-based part 2, you get a wide gap metabolic acidosis. The next step is calculate the osmolar gap, and that will tell you if there's toxic alcohol. Methanol, ethylene glycol is one of the causes of that. And if there is, then there's a special antidote for that. And I'll talk about that tomorrow in the 10 things your intensivist wants you to know. But so that's how you would exclude methanol and ethylene glycol, all right? And this is this crazy calculation. So like, who the hell's going to do that? That's like the winner's formula. So instead of this, just remember this, and that will give you that calculation. So you just put the numbers in, and it'll tell you what the osmolar gap is. All right, so we'll talk more about that tomorrow. So mud piles, the new mud piles is Goldmark. So it is a lot of the same things. You can see it's the toxic alcohols. Oxyproline is just the metabolite of chronic Tylenol use. These are 2 types of lactate. There's a D-lactate and an L-lactate. D-lactate is what people with short gut have. L-lactate is what people in a hypoperfused tissue state have, okay? Methanol, we talked about aspirin, renal failure, and ketoacidosis. So again, the same, close to the same causes. Goldmark is the new mud piles. If you remember mud piles because it's easier for you and you don't give a damn about oxyproline, that's fine. The most common causes when you get into wide gap acidosis, the most common causes are going to be DKA, lactate, and renal failure. Those are going to be the 3 most common causes. 80% of all wide gap metabolic acidosis is going to be from one of those 3 things. Okay? All right, so that's the mnemonic for wide gap acidosis. There's a mnemonic for non-gap acidosis. So you can have an acidosis, but yet there's no gap. And the mnemonic for that is hard up, and I'm just going to run through it quickly. This is the most common cause. It's your fault. You probably caused it, or the hospital that you're picking them up probably caused it. All right, so it's hyperchloremia, acetazolamide, which is Diamox, it's a diuretic, renal tubular acidosis, 3rd most common cause, diarrhea, 2nd most common cause. So most common cause, hyperchloremia. 2nd most common cause, diarrhea. And then ureteral diversion, pancreatitis, just to be concise and complete. So non-GAP acidosis. What causes a non-GAP acidosis? Well, often it's hyperchloremic. And hyperchloremic is typically caused by you or someone else who thinks that normal saline is normal. All right, so normal saline is anything but normal. This is a liter of normal saline. Everybody loves it. It's good. It's cheap. We give it like it's water. The only problem is, I don't know how well you can see that, but it has a pH of about 5.5. Normal pH of the body is about 7.35. So I would ask you then, where is the logic or the wisdom in guy in DKA comes into the ER. He's got a pH of 7.1. We give him 3 liters of fluid, right? What do we give him 3 liters of? Normal saline, right? Because that's what we give him, right? And then we wonder why he goes from a wide gap acidosis to a non-gap acidosis, because we induced iatrogenic saltwater poisoning, right? We created his non-gap acidosis. So that's why normal saline is the devil. There's nothing normal about it. Long live Normasol, out with the normal saline. If they need battery acid, give them normal saline. If they need something that's close to your body fluid, give them Normasol. All right, rant over. So we'll kind of just brush through that. Renal tubular acidosis, that's what you do urine electrolytes for, and diarrhea. So those are the most common causes. So let's talk for a minute now about bicarb. This is for the people who just randomly give bicarb in a coat, under the premise of, well, I mean, they're already dead, it's not going to hurt anything. My response to that is, well, then hell, let's give them a dose of Pitocin, too. I mean, what's it going to hurt, you know? I mean, do we just give things because it's probably not going to hurt? I mean, that's craziness. That's flawed logic, right? So when you give someone bicarb, what happens is, so you have too much H+, which is hydrogen, acid. You give bicarb, add bicarb with that, you create carbonic acid, water, and CO2. So when you give someone with too much acid bicarb, what do you create? More acid. Well, if you haven't finished them off with the 3 liters of normal saline, you throw in a couple amps of bicarb, I mean, that should certainly do the trick, right? So be cautious about giving bicarb. So, because when you give bicarb, you generate more CO2. If you are a young, healthy person and you can breathe off the CO2 that I'm giving you, then you're okay. If you are an old, unhealthy person who is maximally compensated already and you can't breathe off that CO2, I'm giving you a big CO2 load that you can't get rid of. So the wise thing to do, bicarb drips, not bicarb pushes. Bicarb drips, bicarb goes in slower, CO2 builds up faster, it's easier to get rid of it than it is if you just give them a big load at one time. All right. So I had this love-hate relationship with bicarb because I work as a nocturnal intensivist in an ICU, and my day shift partner is a nephrologist. So I'm the one that gets stuck putting in all the dialysis catheters, the temporary dialysis catheters, which is, if you've never seen one, you dilate up 3 times from a central line. So by the time you're done, it's about 2/3 the size of an ECMO catheter. So it is takes a long time. It's kind of dangerous, and at 2 in the morning, it's like the last thing I feel like dicking with, because I'm most interested in getting back to the call room to get some rack time, right? So I had this love-hate relationship with bicarb, because if I can get a bicarb drip hanging, then I can try to nurse them through their renal failure overnight until they kind of correct it themselves, and I can give them a bunch of fluid, and then we might not have to put in the dialysis catheter. So I've forced myself to have some good feelings about bicarb, because it sometimes helps me get a little more sleep at night. But as a rule, bicarb is not a good thing, right? Okay. So then, now we're really into the meat of this acid-based thing. So in the presence of a wide gap metabolic acidosis, you have to go to the second complex formula. So you've done the anion gap, and you have a wide gap acidosis. Now you go to the blood gas, and you want to determine, are you compensating appropriately for your wide gap acidosis? So if you have an acidosis, we compensate for that by a alkalosis, right? If it's a metabolic acidosis, we have to compensate for it through a respiratory compensation, right? So the way you compensate for metabolic acidosis is with respiratory alkalosis. What we need to know is, when I see that you have a wide gap metabolic acidosis, are you compensating appropriately for that metabolic acidosis? Because if you're not, then that tells me I'm going to have to do something, right? So what happens when you have an old guy with pneumonia who is got an altered mental status, and he's in DKA now, or he's septic, and he can't breathe 45 times a minute to get rid of all that acid? What's going to happen? He's going to become more acidotic because he has no compensation, right? So you got to be able to look at the blood gas to know, is his compensation appropriate? That's the winner's formula. That was that formula saw, with all the crazy, who cares about that, right? We use the rule of 15. All right? So the rule of 15 says that if the bicarb on the BMP is greater than 15, is greater than 5, then you just add 15 to that number. That should be the PCO2 and the last two numbers of the pH. If it is, you have appropriate compensation. You just did the winner's formula in your head in 3 seconds. So you look at the bicarb. If it's greater than 5, you add 15 to it. That's the PCO2 and the last two of the pH. If it is appropriate compensation, you're done. If the bicarb, so if it does, the secondary disorder is a pure compensated respiratory alkalosis, because that's what's supposed to happen, right? So if the bicarb is 5 or less, then it is 15. So instead of adding 15 to it, it is 15. And again, if it is, it's a pure compensated respiratory alkalosis. World's happy, dogs and cats are living together, everything's good. They have a primary wide gap metabolic acidosis with appropriate respiratory compensation. If it does not, then there is another primary disorder. So then you have a mixed metabolic acidosis and a secondary respiratory acidosis or alkalosis. But you have a second primary problem, which means that problem was likely existing before they ever developed the wide gap metabolic acidosis. All right, so what's the gap? So you're going to do some calculations. 20, right? Everybody agree with that? So the gap's 20. So then, using the winner's formula, very complex biochemical calculation, what should the PCO2 be? 25. And in fact, it is 25. So you have a primary wide gap metabolic acidosis with a secondary compensatory respiratory alkalosis. Normal compensation. That's what's supposed to happen. You're done. Patient's compensating as he should for this disorder. What's the gap? $17. What's the PCO2? So you have a wide gap metabolic acidosis, and I've looked at these slides a million times, and I saw my first typo. So what should the PCO2 be? That's right. No, I looked at the wrong place. What should the PCO2 be? 27, right? So again, you have a wide gap metabolic acidosis with an appropriate respiratory compensation secondary alkalosis. Got that? Does that make sense? Right? Okay. What's the gap? 10. what should the PCO2 be? See, CO2, and what do you add to it? 15. So what should the PCO2 be? 30. You have a non-GAP metabolic acidosis, right? Because the metabolic acidosis, the GAP is normal, and you have a compensatory respiratory alkalosis. All right, a couple more problems. What's the GAP? $26. What should the PCO2 be? Should be what? 24, right? So you have so the PCO2 is 30. So you have a wide gap metabolic acidosis with a secondary respiratory acidosis, or another primary respiratory acidosis. So he is not compensating as he should be. His PCO2 is higher than it should be, right? It should be 24. It is 30. So he's not breathing off as much CO2 as he should. So he has a second disorder. Does that make sense? Okay. I think we have two more problems. So what's the gap? $30. What should the PCO2 be? Should be what? 22, right? What is it? 15. So you have, what's the primary disorder? Why get metabolic acidosis, right? What's the secondary disorder? There isn't one. It's a primary respiratory alkalosis. That's right. Because the PCO2 is lower than it should be. Understand? When you see that, when you see a second primary respiratory alkalosis, think salicylates or sepsis. And you got to rule those out. So when you see a metabolic acidosis and a secondary and a primary respiratory alkalosis, think salicylates or sepsis. Okay, very important. All right, we're getting to the end here. Complex formula number 3, the final one. So what's the difference between a critical care nurse paramedic and a flight nurse paramedic? It's 1,000 pictures like this on your Facebook, right? So hopefully that's nobody in here, but so that's the difference. Now the difference is what I'm going to talk to you about now. This is where you get the triple acid-base disorder. So you've already got the primary and the secondary. This is the triple. And this is even easier. So for every one change in the anion gap, the bicarbonate should change 1 in the opposite direction. 1 for 1. 1 for 1. And that's called the delta gap. So if you if you're doing 70 miles an hour down the highway and the speed limit's 50, you don't get a ticket for doing 70 miles over the speed limit. You get a ticket for doing 20 over the speed limit. That's the delta between the base and where you are, right? So triple acid-base disorder, you look at the delta gap. So you have, remember this slide? You have the keto acids in there. You get an extra 10 of acid, the bicarb drops 10, the gap goes up 10. That's what's supposed to happen. If the bicarb dropped 10 and the gap went up 20, or if the gap went up 20 and the bicarb dropped 5, then you would have a triple acid-base disorder. So let me show you an example of that. So you have, what's the gap? 18. Okay? You go to the blood gas. What should the PCO2 be? $36, right? PCO2 is 44. So what do you got so far? You got a wide gap, metabolic acidosis, and PCO2 is higher than it should be. So you have the normal gap is 15. The actual gap is 18. So the result is 3 too high, right? So the bicarb should be 3 too low. The bicarb, normal bicarb is 24, the actual bicarb is 21, so the bicarb is 3 too low, the gap is 3 too high, so you have a ratio of 1 to 1, and that means, is there a triple acid-base disorder? No. That's what's supposed to happen. What's the gap? 30. We have a mathematician in the crowd. Wrap that out fast, right? 30. What should the PCO2 be? PCO2 should be 35, and it is. So, the normal gap is 15, your gap is 30. That means the gap is 15 too high. So the bicarb should be 15 too low, right? In this case, the normal bicarb 24, the actual bicarb was 20. It should be 15 lower, but in reality, it's only 4 lower. So said another way, it's 11 too high. When the bicarb's too high, what do you call that? Alkalosis. So you have a primary anion gap metabolic acidosis, a secondary respiratory alkalosis, and a third hidden metabolic alkalosis. Exactly. You have just done triple acid-base disorders. So let's go back to our case. What's your diagnosis? What's this gap? Looks different than the fishbone, right? So what's the gap? Add these two. So 93, 22. His gap at 122 is what? 29. So he has a wide gap metabolic acidosis. What's about the second disorder? If the CO2 or the bicarb is less than 5, what's the factor? 15. What is it? 30. So he has a primary wide gap metabolic acidosis. What's the second disorder? It's a primary respiratory acidosis. What's that tell you about his compensation? He's failing compensation, right? His gap should be, or his CO2 should be much lower than it is. So he's failing compensation. That's somebody that you need to think about, what do you need to do to improve his compensation? Because he's failing. His failure, it's like a burn. When you see a burn, you're seeing them as good as they're going to be right at the scene. It's only going to get worse. His CO2 is only going to get worse. He's not compensating at all, hardly. So that's when you need to get involved. So now you can look at this instead of saying, well, normal PCO2 is 35. He's at 30. He's compensating. Why is his PCO2 low? He's compensating. You're an expert now, not a jackmo, and you can look at this and say, he ain't compensating enough. He's got problems. And we're fixing to send him off to see the wizard. Right. Okay. So, summary, he's got a primary anion gap metabolic acidosis, a primary respiratory acidosis, and a third disorder, metabolic acidosis. So he's got a triple acid-base mixed acid disorder. So he's got a wide gap metabolic acidosis and a narrow gap. So on every patient, every time, check the gap. Every damn time, always check the gap. Use the rule of 15s to identify respiratory compensation or a second primary disorder. Remember 1 to 1 for the delta gap. And if the anion gap's up, the bicarb should correct by the same amount in the opposite direction. All right, so in closing, who's this? Anybody know who that is? We're in Pennsylvania, for God's sake. You should know who this is, you guys. A guy named Randy Pausch. Anybody know who Randy Pausch was? He gave one of the highest rated lectures ever in the history of modern civilization, called The Last Lecture. He was an hematologist at Carnegie Mellon. And he talked about living out your dreams, which I feel like all of us are doing in the job we have. And his advice in his last lecture, he had pancreatic cancer, and he gave the last lecture. Carnegie Mellon had a tradition that when you are ready to retire, the professors give a lecture, and that's their last lecture, and it's their advice to those that come after them. And his advice was, he said, as he was dying of pancreatic cancer, he died 3 months after this lecture. His advice was very solid in that brick walls aren't there to keep you out. They're just there to show everybody else how bad you want it. So keep that in mind. Live out your dreams, climb the walls, don't just stop at it. All right, thank you. I appreciate your time.